Okay, so we both have the same background now.
Yes, sir. We both have the same background.
Background इन्होंने भी डाला मैंने भी डाला. So Jay is here. Jay, can you just tell Vikas uncle how to share it on Facebook very quickly?
Okay, so you have to go to Facebook.
Yes.
And then you have to press the live stream option करके है.
I'm in Facebook. Hold on. See, this is. Can you see my screen?
No.
We cannot see your screen now.
No. Okay. So in Facebook, I am in my page. What do I do now?
Now there might be an option for
Live stream. Yes. Create live.
yeah. And then you link your Facebook to your Zoom via yeah. Just there might be an option there. हो जाएगा.
Camera और connect करके है. Connect your live stream AP to Facebook. Go live in the bottom right corner. Browse this video. Connect your live stream to the live API. Use streaming software.
Yes.
Copy your URL, stream key, schedule, go live.
So you go live now, and then I will share your screen.
Okay. It's not connecting to go live. Share your page, manage school of dental dance settings.
You have a class.
Yeah. 5 minutes.
Allow embedding.
Settings पे होगा ना ऊपर कहीं पे.
Server has stream key. Go to live in the bottom right corner, but that live bottom right corner is not showing anything.
So how do we do?
Schedule.
Or you can record it and then post it.
No, copy URL है ना. See, if you go on that information page where the recording is happening, it says copy URL. So just copy URL and put it in the Facebook Live, and it will go.
ठीक है, sir. I'll put that in. We'll just admit people in now.
Give me another. You can start, but don't share me right now because I'm going to go on Facebook and copy that.
ठीक है. Yeah. Hello, good morning. All those who have joined us today. Another 5 minutes is when we will be starting our presentation. Thank you all for joining in. We have close to around 30 of them. Okay. Good morning, all. It's nice to see you all here. Hi, Nitin.
Hello, sir. Good morning. How are you, sir?
Good. Good to see you all. Hi, Vishaka. Dr. Ashwini, Dr. Diksha, Dr. Sunil, good morning. Okay, I think these are some challenging times that we are all having with the COVID And I hope you're all staying safe, staying home. And it's a great opportunity that, we could have with us Dr. Ashish Kakkar to give us today's presentation on all tissue lasers in implant dentistry. We are just waiting for a few more of you to just join in with us. And then another couple of minutes, we should be starting our meeting. The presentation is going to go on for an hour, so in which we will have almost 45 minutes of presentation. And then after that, you will have another 15 minutes dedicated to question and answer session, which will include a lot of things, both on lasers and implants. So you could all join in, and it's a great opportunity for all of you to connect on this forum. And I hope and seriously wish that this is going to be a great meeting and also a great learning experience for all of us. Wow! So we are already into the first. We have not started at 11 yet, but we are already almost we are around 25 of us here. So are you all from India, or there's someone who's joined us from outside India also?
Vikas, can you hear me?
Yes, yes, I can hear you.
Can you give me the access for recording this permission?
Yes, I am recording it.
No,
I will.
I can record it on my system as well. So
Yeah, you could.
So you have to give me permission for that.
I'm not sure how, sir, right now.
Sure. I'll take it from you.
Right, I'll just give you an introduction. Okay, I think today's topic, all of you have read, all of you have come in. It's an honor for me to introduce today's speaker, Dr. Ashish Kakkar. He's a graduate from Maulana Azad Dental College and Hospital. He's attended his master's post-graduation from Eastman Dental Hospital, London in prosthetic dentistry. He is also a graduate certificate specialty in prosthetics from UMJ New Jersey. He's been in private practice for over 25 years and a consultant at Indraprastha Apollo Hospitals, New Delhi. He's an international well-renowned speaker with presentations at IADR, WCOI, ICOI, and ICOI World Congress. He's the founding president of Academy of Oral Implantology. He's also an adjunct assistant professor at Rutgers School of Dental Medicine, Newark, USA. He has active involvement in clinical research and dental devices and dental implants, and has a patent to his name. He is a clinical mentor for Noble Biocare implant training and also the DGOI implant course. He's a fellow and diplomat of the ICOI and honorable member of the BADI, fellow of the ITI. He is extensively published internationally and author of the textbook Oral Implantology. So I please welcome Dr. Ashish Kakkar. Sir, the screen is all yours.
Thank you, Vikas, and I welcome everybody to this presentation. I know we're going through some very, very tough times in our field, and like it or not, things are going to get tougher because what we are hearing is not very good news. We probably have to put a brakes to our practice for a short while, starting immediately, and we should try and limit our work only to emergency care at this moment in time, so that we don't risk our patients, our staff, our co-workers, and most importantly, ourselves and our families. So that's a very important message to look into. Having said that, today we are going to talk about lasers and can you all see my screen over here? Is that?
Yeah, we can see your screen. You need to share your screen, sir, for full view. You need to share your screen.
Yeah. Can you see that now? Is that?
Yeah. Now that's good. Now we are able to see you, sir.
Okay, so I think from this point onwards, because you take over as the host, because there's a lot of people waiting in the waiting, in the waiting room, because I will be doing the presentation, so it may be easier for you to take over. So what we're going to talk about is all tissue lasers in implant dentistry and or even general dentistry. We'll start with a little bit of general dentistry. So Vikas has been kind enough to do a nice introduction. Vikas is a good friend and we work together on several things, several levels. I'm currently a senior consultant at Apollo Hospital and practicing in Delhi. So we all are aware that dentistry is an amazing blend of science and clinical practice. Most of us are dentists, we are also very good artists, and it continues to evolve, and the profession continues to evolve for a much better patient experience. What does the patient look at? What does the patient want when he comes to you? He wants a good technology. He perceives technology as an important adjunct for more comfortable and less stressful treatment compared to what we had maybe 20 years ago, or even longer. I mean, I come from a second generation of dentists. So when I saw what was happening as I was a student, when my father was working and what I'm doing today, there is a complete difference in the technology. And I think technology is really driving us to a different level. And the ultimate goal is to provide our patient with something very, very comfortable. So with the evolution of technology, I perceive that fewer traditional instrumentation will be utilized, and the old-fashioned techniques will be replaced by the less invasive ones. And what could be less invasive than using a laser gun to achieve your target, from a distance, instead of using our conventional instrumentation. So whenever a newer technology is introduced into our profession or any other field, we need to first understand the clear idea of the vision, goals, strategies of implementation, how we integrate this technology, and whether this upgrade can be a success. Because it could be very frustrating to get new technology, purchase all this equipment, and only to find out that these things are not of much use in our practice. And we've seen a lot of things come and go in the field of dentistry in the last maybe 15, 20 years. Lasers have continued to evolve from a large boxy unit where the units were very, very bulky, and to very, very user-friendly, efficient units now, which are available for our practice. So the lasers have the ability to replace the old standbys, such as our dental handpieces, scalpels, chisels, and many more instrumentations. A little bit about aerosols we will talk about. I know it's a buzzword these days. So we will talk about aerosols also as we go on in the hard tissue laser. In the Hindu mythology, light is always being treated as a healing factor. If you look at the literature, there is lots of papers out there where they show that the light actually turbocharges our cells and actually helps us to heal. And this is what we are playing with. We are playing with light, and we are getting. Vikas, you'll have to mute yourself. So if you are using the light and color to heal the cells, it is always to an advantage. And there are so many papers which have been. I don't know how many of you still use conventional instrumentation. If I do put, give me a second. I'll have to kind of mute. That's better. So if we look at these instrumentations, a chisel and a mallet, I mean, my patients would run away from the clinic. You know, you are actually. I was trained to do this. I mean, when we were doing impactions and other surgeries in Maulana Azad, we were using these instruments routinely. Uh, However, now I think I would keep it restricted to my shelves and my drawers. I would not even take this out to intimidate my patients. So laser acceptance in dentistry has been very slow. However, if you look at medical profession, lasers have been used or are being used for last 10, 15, 20 years. Look at the ophthalmic surgery, ENT surgery, dermatology, which has come to a brand new dimension now where new lasers which have been put to remove tattoos, to depigment the skin, to change, the skin texture. All kinds of things are being used in this field of urology. You know, they are using lasers to approach certain difficult areas or even to operate on neoplastic lesions. And of course, in the spine surgery to remove, compressed disc or, all kinds of things are being used. But acceptance in dentistry has been slow. Uh, there is significant advantages with laser. It's less invasive, provides better hemostasis, it produces a strong bactericidal effect, and it promotes better healing and a speedy recovery from all the wounds. And also the speed and efficiency of cutting with hard tissues is definitely there, and you're only cutting the target tissue because you're being guided with the light. And obviously there is no vibrations of the dills. So lasers have been based upon the wavelength you're using it at. So, you know, what kind of wavelength is being used. So that classification is according to the wavelength. If you look at to the left of the screen, you can see the argon laser and the diode lasers, which are more in the targeting area of the melanin and water, which would mean a soft tissue spectrum. And if you look at the YAG lasers, the ND YAG and the erbium YAG, which we are going to talk about, specifically the 2780 erbium chromium YSGG laser, that is actually an all tissue laser because it also targets hydroxyapatite, which means you can do hard tissue work, including bone and teeth. So one word about soft tissue lasers: they cut, coagulate, and provide hemostasis. Diode lasers have become the most popular tool in dentistry as soft tissue handpieces, and the prevalence of treatment and reliability and ease of use is actually making them very popular. Also, they are not as expensive as the hard tissue lasers. And if you look at the wavelength, they are working between 800 and 1000 nanometers, and these wavelengths are very well absorbed in the soft tissue pigmentation and the hemoglobin. So when you switch from your rotary instrumentation for telephones to smartphone, people in dentistry also move from electrosurgery to diode laser, and I think these are getting very, very popular. And you can use it for various applications in dentistry, like crown lengthening, frenectomies, operculectomy, taking care of certain ulcers, depigmentation, and also for low-level laser therapy for healing, also for bleaching, second stage surgery, opening up small punches in the tissue. So there is so many applications which are there with the diode laser, and the healing patterns are definitely much, much better. Obviously, what is happening is we are actually heating up the fiber. There is a semiconductor which goes through a certain modulation. I'll not go over all of that. And the hot charge activated glass tip actually is ablating the tissue. So diodes do not cut the tissue. Can you just mute everybody, Vikas, if you don't mind? Because I can't, getting a little background noise over here. So the device that is closest to the diode laser is the electrocautery, but definitely there is a lot of difference in the mechanism of action of both of these gadgets. Uh, Obviously, diode lasers can be used in patients with pacemakers, so there is certain advantages of using the diode laser. Laser versus scalpel, obviously, lasers are perceived as an obstacle. The only obstacle is probably the cost, but I think the advantages would be immense if you're getting less pain, minimal bleeding, less anesthesia. The anxiety of the patients is decreased. Sometimes you can only use surface anesthesia to accomplish certain procedures, and a reduction in healing times, and all kinds of different things. So let's go over the first case over here, because I think we would like to see more and more patients being treated with this. So the range of these lasers in dentistry would are immense. Let's go over a few of them. uh, so this is a case of a 58-year-old male who had a buccal mucosa hyperkeratosis, and on the mandibular left side were localized lesions, and patient has been a smoker. No pain or swelling or irritation in the area. The patient was from Atlanta, and then they had a biopsy done over there, and the biopsy diagnosis was benign leukoplakia and hyperkeratosis. So this is what the patient presented to me with in 2016. And I'm not advocating, I'm not saying that it is going to reverse this lesion. Obviously, smoking cessation has to be done, and all kinds of personal habits have to be taken care of along with this. But having said that, this is the case we did, and this is what we achieved and a recall in 2018. So in about 2 years after doing the excision removal for these lesions, we get complete healing of the area and reversal. And our own diagnosis is very similar to what they had reported, hyperkeratosis with squamous hyperplasia and no evidence of dysplasia. So I'm not trying to advocate that this is from last year. I'm not trying to advocate that this is going to reverse the lesion. I'm just saying that it's an adjunct. Obviously, you need to combine the therapy with some antioxidants and smoking cessation as well. So this is what the scope is. Another case where patient had some implants placed, and patient had a phobia of scalpel and blades and sutures. These are early days. These are, we all know we were using tissue punches like over here, and then going for flapless approaches. This is what the patient had. And if you look at implant over here on the lower right side, and over here, and then fractured tooth over here. All these had to be removed. They were all failing implants. And this is how the patient was there in 2010. Now, this patient obviously would have benefited with some implant treatment. Can you hear me over here? Because I think someone muted me. Am I audible?
Yes, yes.
Okay, great. Thank you. Hi, Sanjay. How are you? So look at this. We had a good width of the attached tissue. And at that point in time, we decided to go for a flapless procedure because the patient wanted minimal anesthesia and the patient wanted a minimal amount of surgical intervention. So this is the width of the tissue. All we did was made some small punches with a diode. And what you see over here is the connective tissue. We just removed the epithelium. And on the contralateral side as well, we did a similar approach. Now, these are the paralleling pins. This is what one day post-operative view look like. I mean, this is actually really amazing to see the transgingival healing in this patient, and it's relatively painless procedure for us. Quite amazing to see that. And after the 3 months of healing, we go back in. You can see the good soft tissue contours, maintenance of our attached keratinized tissue. And at this stage, we just did an impression. We replicated this tissue. Ira, there is some line on the screen, I think. Can we remove this line from the screen? Anyway, forget it. Doesn't matter. Thank you. So in today's world, we would probably do digital impression or a digital scan, especially with all the things that are happening in the world. The less contact you have, the better it is. But in any case, 2011, this is what we achieved, and we were able to get a very good result for our patient. This is over 10 years ago. These are some of our initial experiences, and you can see how beautifully the soft tissue is integrated with these implant restorations. And 2011, everything seems to be very much under control. So if you look at what we can achieve, there's a lot what we can achieve with even diode lasers. Let's move on to the erbium family, or the hard tissue lasers, which are of different wavelength. And they will ablate anything with water. They're more of an all tissue situation. You can remove bone for crown lengthening. You can use them in endo, like over here, for deep disinfection. You can see how nicely these bubbles will actually go down.
Look, the bubbles are creating
Right over here, all the way down
along
in the lumen of this tube. And similar situation can happen in your root canal treatment while disinfecting and cleaning with a bactericidal effect. So it is actually very, very helpful to use it in root canal treatment as well. And this is the laser that I use. There's a clean disclaimer over here. This is my work. This is what I am doing. This is not a sponsored lecture. This is complete scientific. I have no financial interest in any of the products which I'm going to be showing. And I'm not getting paid for this lecture from any of the companies. So whatever I'm showing is basically science-based, and we will go over the evidence, because there is also publications that we have done along with this. Let's have a look at another case. This is a colleague of ours, maybe some of you will recognize. It's a 65-year-old male with a history of lip biting and an irritation fibroma of the patient on the lower lip, present for the last few years. So I met this gentleman at a party, and I told him, I said, "Sir, why are you going around with this lesion?" He says, "No, I'm too scared, to get this done." And this was in a luncheon party in a family wedding. And I said, "Listen, let's just go to the office. It'll take me 15 minutes. I'll take this off." He says, "But evening we have the function, the main cocktail event with the band and everything." I said, "I promise we will have a drink together in the evening. Let me work on this." And this is what the lesion looked like and how we approached it. I mean, this is probably more or less a real-time situation. I'll get rid of the music. So basically, we're just giving a little bit of anesthesia around this fibroma so that it gets a little elevated using our MZ4 tip. We're just outlining now that area which we need to remove, outlining our incision area right here. And imagine if you'd done something like this with a blade, what kind of trauma you would have, encountered for this patient. And again, we go around the lesion.
हाँ ओ कहाँ से ले हमरो क्लास से ले
So at this point in time, you can see the lesion has actually been averted. Everything has been taken out, and there is no bleeding. There's a little bit of swelling, which is probably there due to the anesthesia. And then in about a couple of weeks, he sends me a picture and saying, "What a relief," and relatively non-invasive and straightforward with no stitches, minimal amount of anesthesia, and excellent healing. Another case where this is another friend who had history of multiple periapical surgeries since 1992 and had this kind of a huge lesion because of the multiple lesions, multiple areas that were operated on. Just look at the CBCT over here and look at the expansive lesion with no buccal plate. And obviously all these teeth have to be extracted. We need to degranulate the lesion. This has been done about 1 year ago. And this is what the CBCT shows. Clinically, again, we just extract the teeth, look at the cavity. We are always making sure that we are cleaning this lesion. The idea is to, number one, kill the bacteria in this area, remove the granulation tissue, and try and eliminate the functions or the duties of the macrophages to minimize the load with minimal invasive target decontamination in this area. And this is what we are able to achieve. I don't think we will be able to achieve this kind of a thing with a conventional surgery. And the healing patterns would obviously be very different when you compare it to conventional surgeries. This is immediate post-operative, just with 3 sutures, we just closing that area up, and a temporary bridge was fixed the same day. Post-healing, this is in about 4 weeks, we give the patient a permanent bridge. Look at the nice soft tissue and the hard tissue reactions that we have been able to get for this patient. And I don't think we would have been able to achieve such a clean result with conventional surgery. Look at the microvasculature in the area where we had operated, and look at the width of the attached tissue. There is some healing, which is slowed down in one area, but other than that, everything else looks to be very much under control. Laser treatment and applications in periodontal treatment is a complete different topic in itself, but these are the areas where you would, use them in perio treatment. And for me, I use a combination of both the hard and the soft tissue, a diode laser for perio treatment. And that we can probably cover as a separate lecture at some other point in time, because that is a complete different module on its own. The more number of implants we do, the more peri-implantitis we get. I mean, it is something which is related to several things. And the condition results with bone loss, inflamed tissue, gingival recession, and sometimes eventual loss of implant itself if it is not treated. So the idea is to have an early diagnosis and try and do the treatment for these lesions so that we are able to get some sort of a balance and some sort of a stability for these implants. So if you look at peri-implantitis, you can start with small C-shaped lesions which can actually go down deep into these tissues and get some sort of a mucositis over here. Sometimes it's a retrograde peri-implantitis from an infected tooth in the neighboring area, and then you can expect some sort of a bone loss which could be detrimental to the implant success. Now this is just treating the surface of the implant with the laser, try and decontaminate the area. And I don't think any hand instrument would be able to go into these areas because the target is different, and the laser beam actually goes into completely blind areas as well. So if you look at the peri-implantitis, right over here, one of the main causes of peri-implantitis is the residual cement, and more people are now advocating cementless restorations. This is one of those cases where there was tons of cement which was there under the fixed bridge. And you can see the patient has a lot of inflammation and granulation tissue. So I will go over a few techniques to avoid this excess cement in case you are using cement retained restorations. And this is the area that we are challenged with right now. Is this implant going to fail? Probably not, but then we will not have the same mechanical situation as we did with the implant if we had a complete bone surrounding it over here. So here we are just trying to eliminate all the granulation tissue. You can see it's a non-contact situation. There is no contact between the tip and the target tissue. So all the hard tissue lasers, if you're working in osseous areas, you would have a non-contact radial firing situation, and chunks of these granulation tissues would then come out. Again, what we are doing is we are targeting the tissue, we are eliminating infection, and biologically cleaning that area and reducing the inflammation. Just look at all this decontaminated area, which would, and then you actually can also modify the implant surface, because most of our implant surfaces are rough in nature, and there is some bacterial endotoxins that would go into these small roughness areas. So it can be modified and cleaned, and sometimes you're using chemicals means as well. But I think the laser works a lot better. There is more and more evidence that is showing. And at this point in time, you could use a bone graft substitute. Obviously, it's never going to integrate, but it's going to provide a mechanical barrier for the soft tissue to not fall into place. There is another case which we had done in 2004, where we had placed certain number of implants in this area, and then we get peri-implantitis right down to the last 3 threads. Is this implant going to fail? Can we salvage this implant? That is the question. And in 2015, we get this patient back with this lesion, and a similar approach was planned for this patient. And then after degranulating, we just added some beta TCB HA, and then you can see the nice integration. We've actually been able to regenerate at least 8 or 9 threads of new bone. Is this implant still in place? Yes, it is. It's been now several years that the implant is in function, and if it gives us another 5 to 10 years, I think the implant has done its job. Obviously, we need to make sure that the patient keeps a very good oral hygiene and doesn't and comes for a regular recall. So if you look at the implant dentistry, where the lasers would help us prior to the implant placement, during the implant placement, after the implant placement, during uncovery, during prosthetics, and in the maintenance phase. There is all kinds of procedures that we can accomplish for our patients, right from disinfection of extraction sites, which we will go over. We've seen the degranulation. We can make lateral windows for sinus elevation, flap incision, laser-assisted osteotomies, low-level laser therapy for healing, and then making small trapdoors for uncovery of the second stage of the implant, soft tissue recontouring, hard tissue recontouring, and then during the maintenance phase as well. So, I mean, there is, at every point in time, the implant therapy would, the laser therapy would help us to attain this. This is an interesting case. A patient came to me with mucositis, and patient's quite happy with this. Obviously, the surgeon messed up over here. The implant was probably placed at a different level as compared to where it should have been. Now, the patient's complaint was not the smile, was the bleeding. And why does this happen? You know, we are all aware that the bone loss after the extraction is inevitable, you know, because if we don't try and take care of certain factors, we know from our studies of Tolgren, Atwood in 1962, 1963, Johnson also in 63, Carlson and Pearson 1967, Shroop more recently in 2003, and then Cardropoli and Araujo have done some landmark work on post-extraction bone loss, which happens, and how we can maintain or prevent this bone loss so that we can get our good housing for our implants. So it could be because of the infection, advanced periodontitis, lesions like this, where you have already infection in the area, or you have periapical infection. So you would get bone loss, and the alveolar ridge will decrease in volume and are this could be significant and, excuse me, detrimental for a conventional implant placement. So there is two fundamental detrimental concepts. One is the biomechanics, which is defined by the bone, and the aesthetics, which is defined by bone and your soft tissue. So if the available bone is inadequate, bone needs to be augmented at a second stage. But why should we get into a situation where you need to augment bone? So you need to do a preservation of bone right after your hopeless teeth, which are extracted after endo or perio or prosthetic or orthodontic failures. And the patterns of bone healing would be very different in every case. The longer you wait, the worse the situation would be. And as I said, Araujo has done some studies. Araujo was in India last year around this time, and we got to spend a good time with him, and he did a seminar for the AOI in Delhi as well. So I think this was a learning exercise, and I think he's done some landmark work, and this is one of his papers from 2015. So let's have a look at this case over here, where we had a hopeless molar which was extracted. And then after the extraction was accomplished for this patient, we did bone graft in this area to do a ridge preservation. And 5 or 6 months later, we go back in and then place an implant in this area. And you can see that the bone is quite nicely healed. You do see some changes in the soft tissue and some changes in the contour. Imagine if we had not done bone graft or a ridge preservation in this area, how difficult it would have been for us to place an implant in this area. So you do see some residual bone material at this stage. The width is very adequate for placing an implant. So we go back in right now and inspect the area. And at this stage, we do a biopsy of the area because we want to know what kind of bone was there and what kind of bone we are dealing with. Just do an indirect sinus elevation because the vertical height is also a bit compromised. And then go ahead and place our standard implant. If I'm doing about 1 or 2 millimeters of indirect sinus elevation, I don't tend to use any bone graft substitute because the blood clot is usually enough and to achieve this. And just trying to inspect and see what kind of depth I've been able to achieve. I'm just expanding the bone a little bit because we know the maxillary bone is a bit soft. It should be done with some caution so that you don't break the buccal plate because it's already the weakest point in the system. And as the patient is breathing in and out, you can see that the blood is going in and out. So we know that the sinus Schneiderian membrane is intact. This is an older design of the implant. It's a white platform implant, a 5 millimeter implant, 5x10, which is going to be sufficient for replacing our molar, the first molar which is there. And try and achieve a good primary stability to place our implant in this missing molar, which was modified, that area was modified by doing a bone graft at the time of extraction, do a socket preservation or a ridge preservation at that point. So what we are able to achieve is a ISQ of 67, which is very, very desirable. From the buccal side, which means the that the palatal bone is quite strong, and ISQ of 73 from the palatal side, which means the regenerated bone is actually very, very strong. And anything above 60 shows us to be a very, very good primary stability. Obviously, we are not going to do an immediate load for this patient. We are going to go for delayed loading, and this is what we end up with. A crown, you can see that we always try to shrink the occlusal surface. And in spite of our best efforts, we still get some sort of a remodeling in the bone. This is even after doing a rich preservation. You remember we did a biopsy. We see the specimen over here. We see some very good new bone formation right over here, and a good bonding between the graft material and the patient's host bone, and with the live osteocytes being present. Interestingly, in the biopsy, we get bone content of about close to about 35 or 36%, and connective tissue about 60%. Now, all the bone that you regenerate or bone graft substitute that you put, the maximum bone generation is about between about 35 to 40%. And if you are using synthetic bone, it's a little higher as compared to freeze-dried bone or demineralized bone, or even xenograft. Xenograft seems to be the lowest in the spectrum. This is a 2-year post-op view, and this is a 4-year CBCT. You can see right over here where we've been able to elevate the sinus. We did not use a bone graft substitute, but we do have good coverage of bone. See that the crestal bone is maintained and the implant position seems to be stable. Would I have been able to do this without using the laser at the first stage? Probably not. I mean, so it is important to have a laser as an adjunct for all these procedures. Another case, which is a more recent case, where we had an impact. Right over here is the area of interest. You can see that this is completely gone. This tooth is grossly decayed. This tooth needs to be extracted. So we decided to do an extraction for the 7 and do a socket or a ridge preservation. These are the CBCT views. This is what it looked like. And there was lots of granulation tissue. We use our YSGG laser to completely degranulate the socket. And at this stage, we just place a synthetic graft over here, close it up. And the patient was too scared to get the extraction of the 8 done. However, it was done at a later point in time. One word about extraction: it has to be done in the most atraumatic way possible, because of the fact that we need to preserve as much hard and soft tissue as possible, especially if you're working in the aesthetic zone. This is post-operative healing in 24 hours. You can see how nicely the tissue is getting adapted. I would not expect this kind of a result if I did a conventional surgery, which was not laser assisted. At the end of a week, removal of the stitches, you can see some graft being exposed. Am I worried? I'm not worried, because the granulation is forming and this is going to cover it. And in 5 months' time, I see a good healing in the area. CBCT shows that the bone graft is nicely integrated, and we've been able to preserve the buccolingual width as well. So at this stage, I will plan to do my implant. This is just showing the density of the bone and the Huntsfield units, and the new bone formation which is there. It's a little less radiolucent than the host bone. Does it bother me? I don't think so, because when we go back in to see, you can see the nice buccal plate, and this is going to again calcify over a period of time. At this stage, we place our implant in that grafted area, and we also accomplished our extraction for the lower 8. This is the post-operative healing. In 1 week, again, we are using laser-assisted drilling, and you can see how nice the tissues are looking in at the time of suture removal. The time of re-entry in about 4 months, you can see that implant is nicely stable, And at the second stage itself, we are doing our scanning, intraoral scanning with a scan body for the Straumann implant that we are using. And within 2 days, I'm delivering the screw retained crown, everything done in-house for this patient, and nicely integrated prosthesis. And you can see the comparison between 6 and 7. I'm shrinking the occlusal surface down between 25 and 30% so that I have my forces directed axially into this implant. Obviously, we've done a lot of work in the past on ridge preservation. This is one of our multi-center studies. It is open access journal. I can give you the references if you inbox me later. And we've also done some animal studies way back in 2014, where we were working on the rabbit calvaria and using different kind of uh, bone graft material. This is just the calvaria after the sacrificing the animal. And we've had several publications on this, including presentations at the EAO. And this is the case you just saw a little earlier. And again, a part of our series, which we did more research using a synthetic bone graft substitute. This was done at Yanapoya University with Dr. Shashikant Hegde and Dr. Nikhil Deshpande, and in combination with University of Freiburg in Germany, where they gave us all the histologies. One of the more important things to consider is the radial firing tip. And I think this tip is the key to success for our hard tissue lasers. So if you look at the radial firing tip, it actually fires not only straight, but also in a radius of, and 85% of the laser energy is actually emitted into lateral directions. And imagine getting into a socket with this kind of a tip. You're actually not only cleaning the apical area, but you're also cleaning the four walls of your osteotomy site, and it actually leads to a very good disinfection and cleaning of the area. We already talked about post-extraction resorption. This is one of the slides from a paper from Tübingen from long time ago, where the Freilet 1 implants were used, where 4 extractions were done. This is not my paper, but it's just an eye opener to see how the tissue reacts to placing immediate implants. There we did 2 immediate implants were done in the centrals, and the laterals were left. And once you go back in and see that the bone and soft tissue are actually preserved in the areas where the implants were placed, and not in the areas where there was no procedure done. So obviously, implant procedure, if you're doing the implants, you're actually preserving both the hard and the soft tissue. Let's look at this case over here. This patient walked in to my office with this kind of a prosthesis. These 2 teeth, the 2 centrals, were actually hanging in the air. And every time the patient talked, these teeth were actually flipping. This is the CBCT where there was minimum amount of bone. And what we did was did a little nasal lift and placed our implants in that area, and then just grafted with the laser assisted surgery. This is 24 hours post-operative. And then we went ahead and placed our abutments. After about 2 weeks, we did an initial early loading with some temporary prosthesis, and this is what the final prosthesis looked like. I mean, it's actually very well integrated. We were aware of the fact that these crowns will be larger or longer cervico-incisally, and patient was informed about this. And this has now been in function for over 10 years. So, probably if I had lifted a flap and done all sorts of invasive procedures, I would not have been able to achieve this kind of simple result. Again, another case where we had fractured premolar post-endodontic treatment, which had to be extracted. And a lot of times, this is actually not an endo, this is periapical lesion. So a lot of times you will get into a situation where you would have the crown in your forceps, and the root in the socket. And this is not something new to us. So we need to go with the most atraumatic way. You can see the tons of granulation tissue which is present around this. Maybe under normal circumstances, we would have looked into doing a delayed implant or a semi-delayed, immediate delayed implant in 4 to 6 weeks. But over here, we are using our hard tissue laser to degranulate the area, to detoxify, and achieve very, very good clean. You can see the amount of granulation which is now falling off, and degranulating the area to make our host site clean and receivable for an immediate implant in the area. At this stage, we are also using certain drills. This is a Zyve implant. In my practice, I'm using 4 or 5 different systems depending on the comfort level of the patient and what is the indication. And over here, we are using in a palatal direction our drilling in a sequential form right over here. And then once again, making sure that the implant bed is absolutely clean and sterile. And this is just a trial. And now the implant is going to be placed into that osteotomy site. Again, for all my implants, I'm doing the ISQ measurement because that's the only way of documenting the stability progressively for all our implants. You can do it at the second stage. And if you have you can see how good stability we are getting. So if you have a screw retained prosthesis, you can do it even on a yearly or a 2-yearly basis, depending on how often you want to remove your prosthesis for maintenance. So you saw that the healing cap was actually getting interference. Now, if we have a situation like this, and if we start using our drills to remove that lip of bone, we would actually get into issues with damaging the implant head or the implant surface. But however, if you use a laser, a hard tissue laser to remove that lip, it is relatively straightforward and relatively simple to achieve this so that your healing collar actually sits into position. So this is the final restoration for this patient after about 4 months, and it's very nicely integrated with the rest of the mouth. As we talked about making tissue punches, this next patient over here was actually on blood thinners, and the doctor, the cardiologist would not allow us to stop the blood thinners, but the patient was demanding certain implants in the edentulous area. So we got a CBCT scan done for this patient, and once the CBCT was done, what happened over here? I think we've lost the screen sharing. Okay, let's try it again. Vikas, is my screen still visible?
No, sir, it's not visible.
Just give me a second. I think we're some technical issue over here. Don't worry, I'm still here. We'll be back in less than a minute because I've been able to. So it's important to understand that, in patients who are compromised from Are we back now?
Yes, sir.
Yes.
Okay. Thank you for waiting. So over here, we got a CBCT done for this patient. And then we decided to approach it in a flapless way, like we did earlier for that other patient. And you can see the width of the bone which was available. So we need to go with a minimal invasion in these areas. So we are using our all tissue laser over here to mark our implant sites. So we are actually doing small stab incisions in our potential implant sites right over here. So that's the first one till we reach the connective tissue. Obviously, you can go with tissue punches as well, but you will see the patterns of healing that we get with the YSGG erbium chromium laser, and it's just outstanding, the healing patterns. And from a pain point of view, there is hardly any post-operative pain or swelling for this patient. So you really don't need to give too many medications, not many painkillers. And with the least invasion, you can see that there is hardly any bleeding in that area in spite of patient being on blood thinner. So this is what we were able to achieve for this patient, because we already knew the amount of bone which was available to us. This is the left side of the screen is in about a week's time. I don't think I would be able to achieve this kind of a healing in 1 week's time with any sort of a cold blade procedure. And this is after during the loading. Right over here, you can see the beautiful soft tissue reactions that we are getting on both of these implants over here, and our prosthesis, which is screw retained. Simple, straightforward, non-invasive procedures. Patients' confidence is really good. Patients are aware that they are going through a high-tech procedure. There is no stitches, there is no painkillers involved, there is no antibiotics involved, and it is all due to the planning, number one. Number two, due to the instrumentation and availability of a hard tissue laser. Right over here, this is the upper and the lower. So everything was achieved in a very non-invasive way for this patient. Now, lasers can also be used in GBR procedures. If you look at all these areas where we are decorticating the bone, the patients do feel the vibration of the drills when we are doing the GBR. So if you are using the laser, it is actually much easier and simpler, and less vibrations that the patient would feel in this area. Wow, somebody is working in the clinic. Wow. Anyway. So as I said, no vibration of burrs, relatively bloodless operating field, rapid angiogenesis, no overheating of bone due to air and water coolants, precise surgical cutting due to the aiming beam, and faster healing and less inflammation because of the fact that you're getting quicker surgical times. Also, lasers have been used in therapeutic, low-level laser therapy for biostimulation. That is also very helpful, and there are certain protocols that we use for that. Let's talk about immediate implantation. We've seen a couple of cases earlier. The preserving hard and soft tissue is the crucial goal. There's 5 key points: the extraction, the buccal plate, primary stability, the gap distance between the implant and the host bone, and the soft tissue biotype that we are dealing with. Important to use minimal invasion instruments for these procedures, so that you use periotomes and luxators. Everything takes time, especially the endo-treated teeth, so you need to be patient. The implant actually takes less time than the extraction in most of the cases. So if you are dealing with multi-rooted teeth, like over here, you may be able to section them and then take them out in 2 pieces, degranulate the area, place your implant, the graft, close it up, and then go back in and then place your crown. The implant design also is very, very important, because if you have a good implant design which has good primary stability features, then your overall result would be much better with less atraumatic extraction. Now, the question that comes to our mind is, can we place implant into infected sockets? There is so many reports which are there. The focus questions are, Does the presence of infection compromise the success of the immediately placed implant? What happens to them in long term? Or the presence of infection compromise the osseointegration of the immediately placed implants? And what are the protocols that we have used to address this situation prior to the immediate implant placement in the past? So the questions are plenty. Let's look at a systematic review on the Medline and see what all has been done in the past to achieve this. Let's look at some of these animal studies. Uh, there are so many studies done on dog and on beagle dogs, mostly. Novas et al. Did the first in 1998. And then the human studies were also done by Novas et al. And Casp and Vela and so many other people. And then what is the main criteria? What do we see? The success rate in animal studies was about 100% and human studies was between 92 and 100%. Does that really mean that the success can be achieved for these cases with teeth which have periapical lesions? What are the pre and post operative measures that we need to follow? The key to success, according to most of the research, is deep degranulation and meticulous cleaning of the socket. So this is what we mean by deep degranulation, making sure that there's no soft tissue remnants which are there, and alveolar debridement before the surgical placement of the implant. We all are aware that we will get good cleaning with our mechanical means, but does that really mean that there will be no biofilm left on the socket? We're not really sure, because biofilms will form, smear layer will form on these sockets, just like it does in dentine. So what are the means of cleaning this socket other than mechanical? People have talked about chemical debridement so that the elimination of bacteria is there. What I'm worried about is the zone of inhibition, because beyond the bacteria, the endotoxins that will actually go and embed themselves in the bone. And the internally irrigated drills that are used produce a smear layer similar to what is formed in your dentine. When you compare laser to chemicals, what are the things that you get? The biofilm. If you look at Cusack study, which was done in 2006, use of chemical means can only kill bacteria to about 100 micron deep. However, if you use a laser technology, you can go deeper, about 10 times more, or now with the newer radial firing tips, even more than that. These are reports which are documented. This is the laser system I use. So let's have a look at another case where post-extraction degranulation was done, and this is what we were able to achieve. Placed our implant, the bone graft that we are using, preserving the buccal plate, as I said, and trying and achieving a primary stability for this patient. Even though we did not have a primary closure, we do achieve a primary closure with a creeping of the tissue. At the second stage, you just open it up with a stab incision and then just do an impression. And the soft tissue level is actually much better as compared to the soft tissue level on the natural teeth. It doesn't mean this is going to actually now walk away a little bit and stabilize over a period of time. But this is what we see time and again. This is another case which was done. Time and again, we will see very, very good soft tissue healing and very, very good gingival margins around these treated teeth. So this is one of the earlier cases, another bad root canal, and then we are treating in the same way. Now, this is from our publication that has come out last month. What are the protocols for laser debridement? Number one is the settings that we use. The tip that we are using is an MZ4 14 millimeter tip. You can also use an RFT 14 millimeter tip, which is a 500 micron tip. Power settings between 1 to 2.5 watts with a frequency of 20 hertz, and irrigation and air between 15 and 40% and 30 to 50%. So the tip is inserted into the socket, as you can see over here. Right here, the tip is inserted into the socket, right to the apex, moving it in a coronal direction in a concentric fashion, and each socket is treated as one root, and debridement of each socket is done individually for 40 to 90 seconds, dwelling in the sites which are identified as infected sites. And once the procedure is accomplished, you can actually visualize and appreciate the clean surface of the bone, which actually doesn't bleed for a few seconds. However, when you start using your drills, it will bleed, and it needs to bleed for an osseointegration. And this is the way the tip will work in a non-contact fashion. You can really appreciate how it is actually removing the smear layer and removing all the toxins from the bone. And at the same time, it's preparing the bone. There has been cases where we've actually done no drilling, especially with the self-threading implants. We've actually been able to achieve very, very good primary stability just by using the laser in the infected sockets. Like this case over here, we just extract the tooth, place our implant, place our synthetic graft, again get a primary closure at a later date, and open it up with a diode, preserving the buccal plate, and then our prosthesis, which is placed. This is a case which has a follow-up of over 9 years now. This molar had a furcation involvement. Right over here, you can see the draining sinus, and the extraction was done, followed by laser and implant placement into the interradicular area. In this area, placing our bone graft. This is the day of the surgery. In 24 hours. You can see how clean the tissue is looking. Both the implants are looking okay. This is in 4 months. We place the prosthesis. Good soft tissue reaction in 6 months. You can see there is some difference in the grafted bone and the host bone. In 12 months, it actually looks worse because there is remodeling, and x-rays do show more of the decalcified area. And in about 4 years, you can see how nicely the tissue and the bone is now integrated with the host bone. I would actually contribute this more towards the laser. This is an immediate extraction site. This is a delayed extraction site or a healed site. You can see the bone reaction, which is different in the same patient, same area, same day the surgery was done, but the favorable reaction that you're getting with a laser. So long-term stability is achieved. This is a 5-year CBCT. You can see the lingual bone is actually now overgrowing the abutment, and the buccal bone seems to be so stable. So, this gives us more and more evidence that using lasers in these sockets is actually very helpful for us. Another interesting case where we had a fractured post. In this case, because we'll end in about 10 minutes, if everyone's okay with that. So again, just showing how we are using our radial firing tip over here and getting a degranulation, and now placement of, you can see how clean the implant bed is looking over here. Again, with minimal invasion, you're achieving very, very good stable results for your patients. And then final talking is done with the handpiece. Again, you're measuring our ISQ, the stability in the site, which is 67, which means it's a very, very stable implant. And then placing our bone graft, which we did already. And this is what we are able to achieve for this patient. You remember there was a bad extraction. This tooth had perioapical infection, a fractured post. And in about 3 months' time, this area, even though we have certain, frenum attachments, the area looks so silent, and it looks very, very healthy. So at this stage, we are just going to do our scan for this patient. And once the scan is done, we are just going to place our crown. Again, from where we started off to where we are, minimal invasive with some very, very good results. Again, over here, simple, straightforward case. This is actually one of the first cases we did. We have almost a 10-year follow-up on this. Placing our implant, preserving the buccal bone in this area, placing our bone graft with, and this is what we see in about 3 months time, open it up with a diode. At the same time, we do our impression, preserving our buccal plate, making sure, and at this stage, we are even getting a stippling in our tissues. We start getting stippling in our tissues, place our crown within 3 to 4 days time, and we will see that the interdental papilla will start creeping down over a period of time. This is in about a week's time. This is in 18 months. You can see that the restoration is very nicely integrated. Buccal plate is still preserved. This is after 3 years. Patient is coming in. This is after 5 years. And it's really very well integrated. This is another case. I'll just go over it very, very quickly. Extraction, palatal placement of the implant. This is again a Zyme implant bone graft. Closure, opening with a diode. And at this stage, we do the impression. Now, in order to prevent peri-implantitis, we actually make a template of this and keep our stone model ready. We fill it up with cement, and then all the excess cement is now coming out into the model. So we wipe this off, and we have the minimum amount of cement which is there to be used for this patient. And there is hardly any excess cement for this patient, and we will prevent any more peri-implantitis for this patient. So this is in COIR, Clinical Oral Implant Research. We had done a presentation. This was probably way back in 2014, and we've been working on these protocols for almost about 10 years now. And a very invasive case over here where we had the loss of buccal plate. But then when we go back in, we see that we get very, very good soft tissue and a hard tissue reaction over here. So this is the tooth which was under question, and we get a good follow-up in about 2 to 3 years time, and good bone formation and good bone regeneration. This is a 5-year recall for the same patient. This is that's a 3-year recall. So we have, this is the 3-year recall, and this is the 5-year recall for the same patient. Again, this is the 5-year picture. We already have some sort of, this is the other implant which was used, but the implant which had the maximum amount of bone loss in the buccal area looks to be very, very stable. And the bone levels on both the implants look to be absolutely stable in these areas. This is the publication which we've been able to get. This is as of last month, and I can send you the link for that. What we have found in this case, in this study, in over 7 years of recall, we had only 5 failures out of the 110 implants which were placed, and a success rate of almost 96% in all infected sockets. So the details are there in this paper, and this is hard work of 7 years which has now finally got recognized, and this has actually been published in a medical journal and not a dental journal, which gives us much more confidence. And these protocols are now being followed internationally, and I think with the hard tissue lasers and all tissue lasers, we are able to get very, very good reactions for our both soft and hard tissue for our patients. Patients are much more comfortable, they are pain-free, the healing patterns are better, and obviously you are imbibing new technology in your centers and giving the patient the best possible. So with these words, I'd like to thank you for all your attention. I know I just overshot a little bit, but Vikas, I'll hand it over to you for some questions, if there's any. Vikas, can you hear me?
Sir, you have been muted. Vikas, sir, you have been muted.
Okay. So there were a couple of questions. One of them being that can we do the osteotomy using the laser?
Vikas?
Can you hear me, sir? Can you hear us? Sir, can you hear me?
Because you are audible.
Hello.
Vikas, you need to unmute yourself.
I did unmute myself, but anyway, I just wanted to ask you, there were a couple of questions on the chat. One being, can we have the osteotomy done with the laser?
So can everybody hear me?
Yes.
Yes, sir. Yes, sir.
Okay. So the question over here was, can the osteotomy done completely with a laser? It's possible if you have an aggressive screw design for your implant, and if you have a single-rooted premolar or maybe a single-rooted canine, because most of these sockets are different in configuration. So you need to select your case according to the implant size, but I would definitely advise you to do osteotomy beyond the apex of the root to get some primary stability. Having said that, with experience, you will realize that yes, it is possible. There is industry which is already working on specific tips which
Sir, you need to unmute yourself. You need to unmute yourself. Sir, you need to unmute yourself.
yeah, was that clear?
No, sir, I suddenly muted all others were online. So you could please answer it again.
Okay, so you be online so that I can get the other question also. So I think we got muted in the middle. So I would say that the industry is working on certain tips that would help us to make the osteotomy sites, but these drills are still under investigations because they release a lot of heat. So I would stick to the conventional protocols, as I said earlier, to and use the drills in conjunction with the implants. However, if you do have a socket which has a very straight configuration, you can go for this is possible mostly in the premolars. You can go for a no drill or a slightly modifying the socket with your laser tips to get some good primary stability. But that comes with experience. That's not going to be possible if you're doing it in your first or second or third case. So you need to be a little more experienced in dealing with the bone and the hard tissue laser.
So now the next question.
Mm-hmm.
The next question is from Dr. Shailaja. In the extraction socket, the graft material placed and sutured, but it is exposed during healing. Is there any chance of infection to the graft material?
Okay, so that is the question over here is that if the graft material is exposed during healing, is there any chance of infection? Of course there is. Depends on the graft material you're using. In my practice, specifically for this study, we were only using synthetic grafts. So synthetic grafts somehow seem to respond a little better as compared to, maybe autograft or xenograft or freeze-dried bone, whatever you're using. I would definitely recommend to have them closed, the flaps, with some releasing incisions to get some primary closure. However, in synthetic grafts, it doesn't seem to affect as much as you saw in most of the cases that I presented. Regular use of chlorhexidine and regular cleaning in that area so that the food impaction is not there. These are the key for success.
Right, so there's another question.
Yes, please.
So there's a question on root canal. I don't know you want to take it. Root canal disinfection. Kindly explain regarding the tip type, movements, and precautions.
Okay, good. So this question is regarding root canals. What kind of tips are used and the movement and the settings? So, honestly, I am not doing that many root canals, but there is specific kits available. There is specific root canal tips available, which would actually disinfect the canal. And it is not very different from disinfecting the sockets. The only thing is that the tips are a little thinner and the settings are different. So I'm not an expert in root canal, so I don't really want to venture into this, but I think if you do want, you can inbox me. There is a complete root canal protocol that is there, and I can forward that to you for your pursuit.
Right, sir. Another question. Which laser do you recommend best for surgical removal, that is impaction, pericoronitis, or biopsy, or any minor surgical procedure? Can you please explain the laser value for frequency, temperature, etc.?
Okay, so the question over here is what kind of laser would you recommend for oral surgery, for soft tissue, and for hard tissue? Do I understand that correctly?
Yes, yes.
So basically, again, you need to understand what kind of clinical challenge you're facing. If you have a small lesion, if you do have a soft tissue lesion, you can easily go with a diode laser. If you're doing, say, a pericoronal flap, you're doing a frenectomy, or you're doing small removal of small epilis or fibroma, it is possible to do with a diode laser. Having said that, diode lasers do have their limitations. They do release a lot of heat. If you do have a fibrous lesion, you need to increase the settings, you need to increase the wattage, which means that every time you're increasing the wattage, there is more heat which is generated. Now, a lot of people would say, okay, let me just irrigate that area to reduce the heat. What happens then? So we see that the target of the diodes is in the range of hemoglobin and water. So in the moment you put water, all the laser energy is getting absorbed in that water. So your efficiency is actually reducing. So that is the area where you would then need to use a hard tissue laser, which is an all tissue laser as well, as I discussed. When you go into the bone area where you're trying to remove bone, where you're trying to do bone surgery, a hard tissue laser is definitely recommended. So all depends on what area you're working in and what frequency you're working in. So that is very important to understand your target tissue. Now the target tissue will actually define the instrument that you're using. Because we can take the next question.
So another last question.
Yes, please.
Another last question. One is, what synthetic graft is used in these cases? Number one. And number two is, how long do we have to wait after grafting and immediate implant placement?
Okay, so what I was using in most of these cases is a graft, which is a combination of beta TCP HA 4060. HA doesn't resolve, beta TCP does resolve, and you saw the results that I get with the biopsy. I get very good bone turnaround. This is a commercial product from Sunstar. It was available in India. Presently, it's not. However, having said that, any beta TCP HA which has a similar composition would work in much similar way. How long do I need to wait for an immediate implant? All depends on factors like my primary stability, my ISQ values, the gap distance I have from the implant to the bone, and number of implants that I'm using, and the opposing dentation. So there is all these factors that we need to consider. If I'm getting a primary stability of 65 and 70, which is an ISQ which is quite high, I could go in for earlier loading also. If I'm splinting for implants, I could even go for an immediate loading. If my opposing dentation is a denture, I can also consider immediate or an early load. So the clinical condition defines the loading protocols. It has actually got nothing to do with an immediate or a delayed implant. This would actually hold true even for a delayed implant. And I think Vikas, you would agree with me on this.
Yes, sir. Yes. And can you please share the links of your articles for
Yes, I will. What I will do is all these articles are open access. I can send them. I really don't know how to. If you can inbox me on the Facebook, or if you can make a group, or I can send them to you, or whatever. I mean,
Right, sir. Sure. What I'll do is I will in the chat messages. I'm writing down the email ID of Dr. Kakkar. So all those who want can obviously email it to him or whatever articles are needed. So it's been a wonderful presentation, and thanks a lot for your time. So any more questions will be, you could inbox them, and we will very soon also be putting this recording on Facebook. So those who have missed this presentation from the beginning or parts of it could obviously access it. Thank you all. Thank you all for joining.
thank you, dear Vikas. Thank you all the participants for your time, and hopefully we will be meeting very soon.
Yes, thank you all. So we will very soon meet up and probably come up with the next panel meet where Dr. Kakkar has already finished his training as a COVID doctor. Sir, if you could just explain about your recent certification on the COVID virus. So we would like to, there were a lot of participants asking that we would like to have a discussion on, dentistry post-COVID and how it is going to be post-COVID. That would be our probably next meeting. So Dr. Kakkar, if you could just explain a little bit on the current crisis that we are there and how do you look into about the future of how dentistry is going to be. Hello, sir, can you hear us? Hello. Okay. I think there are a lot of them muted. Thank you all for joining in.
Thank you, sir.
Right. Thank you all for who have joined in to us. We will keep in touch regarding the next meeting, next webinar, and we would come up with some very interesting topics that you would all be very interested in. One of them obviously being on the future of dentistry, the panel discussion on how it is going to be COVID, and when you open up, what is the kind of precautions that you would like to take? Because a lot of people have been asking and have been trying to know how our protocols are going to be. So we would probably come up with that very soon. Thank you all.
Thanks, Dr. Vikas. Thanks.
Thank you.